Our topic today will be minimal stimulation protocols for ART. In the last 3 decades, controlled ovarian hyperstimulation has become an integral part of assisted reproductive technologies. The major role of controlled ovarian hyperstimulation has been to increase the number of oocytes in order to compensate for, 1, inherent biological limits, and 2nd, imperfect laboratory IVF procedures, enabling selection of 1 or more embryos for transfer. The currently used regimens, the conventional approach, these regimens are usually complex, they have high costs, they are time consuming. As you know, the long protocol is still the most used or employed protocol all around the world. It has much patient discomfort. There are shorter complications, especially ovarian hyperstimulation syndrome. There's a lot of emotional stress and a high dropout rate. And there are still uncertainties regarding long-term risks such as birth defects, low birth weight, preterm delivery, and so on. In the context of improved laboratory performance, the need for a large number of oocytes as an integral part of successful IVF program may be questioned. And indeed, in 1996, Edwards et al. Were the first to express concern with regard to contemporary ovarian stimulation approaches for IVF and called for the use of milder stimulation protocols. Indeed, Fauser et al. Were the first to raise this glove and started implementation of minimal ovarian stimulation protocols for IVF. The aims of the mild ovarian stimulation is to achieve cost-effective, patient-friendly regimens by employing less complex, less time-consuming, and cheaper protocols, and on the same hand, to optimize the balance between outcomes and risks of treatment by reducing the complications, discomfort, dropout, taking into account effects on oocyte quality and endometrial receptivity. Since that time, a new society was founded, called it ISAMAR, and this society proposed new terminology for IVF stimulation, the natural cycle IVF, the modified natural cycle, the mild IVF, and the conventional IVF protocols. And these terminologies were also defined. Recently, two definitions were adopted. One was presented by the WHO in human reproduction in 2009, and the last was presented by Fauser in a debate in human reproduction in 2010. The last definition of this approach is the administration of low doses of exogenous gonadotropins for a short duration and or oral compounds in Gnrh antagonist co-treated cycles for ovarian stimulation for IVF, aiming to limit the number of oocytes obtained to less than 8. And in the coming talk, we will see why 8. So this is the most recent definition of mild ovarian stimulation. Now, there are several protocols when we are addressing this issue. There are several protocols that can be used in this context. The first is the Gnrh antagonist, natural or modified natural cycle, clomiphene citrate and aromatase inhibitors, late start gonadotropin treatment, late follicular phase LH or HCG replacement that we will mention. The short Gnrh agonist, although may have a room, but there are still no data till today in this context. Now, when we are talking about the Gnrh antagonist, you know that the introduction of these compounds into clinical practice has allowed for the beginning of milder stimulation approaches for IVF treatment. The Gnrh antagonist is a more physiological approach. The use of the antagonist during the mid to late stimulation phase allows for the initiation or IVF treatment in a normal menstrual cycle with an undisturbed recruitment of a cohort of follicles during the early follicular phase. And this approach enables the endogenous intercycle FSH rise to be utilized rather than suppressed, resulting in a reduction of medication needed. And it is very important to notice that. And as you know, in already 2006, a Cochrane review has summarized, after revising 27 eligible IV RCTs, the Gnrh antagonist, compared with the long protocol, has a significant reduction in the analog treatment, in the gonadotropin administration, in the amount of ampules, and in the incidence of severe OHSS. What about the natural cycle? The cost of the natural cycle, as we know, has been calculated to be 20 to 23% of those of the stimulated cycles. The ongoing pregnancy rate per started natural cycle have been reported to be about 7%. However, these results are hampered by a high cancellation rate due to premature LH surge, premature ovulation, and reduced chances for successful oocyte retrieval. Verberg et al. In a recent review of this topic has summarized the reports that are talking or they are researching the issue of the natural cycle in IVF. Only randomized controlled trials were included, and the results, as you can see here, were good results. Now, there are strategies that can improve the results of the natural cycles that have been mentioned in the literature. One of them is to use HCG for final oocyte maturation, to employ indomethacin to postpone follicle rupture, to flush the follicle, or to offer the treatment as a series of treatment cycles, not only one, but one after the other. But maybe the most promising from that all would be the modified natural cycle. What is the modified natural cycle? In the modified natural cycle, the occurrence of a premature LH surge is prevented by the use of a Gnrh antagonist during the late follicular phase. The ongoing growth of the dominant follicle is supported by the addition of exogenous gonadotropins, what we call the add-back therapy. In most studies, the Gnrh antagonist and gonadotropins are initiated at a follicle diameter of 12 to 17 millimeters.